Welcome to Deloitte Center for Health Solutions, the report on breaking the dependency cycle, tackling health inequalities and vulnerable families. My name is Mette Lindgaard. I'm responsible for social services in Deloitte.
Hello, I'm Karen Taylor. I'm the Director of the Centre for Health Solutions, and I'm responsible for this report, which we're going to talk to you about very shortly.
And I'm Rebecca George. I lead the public sector practice here in the UK, and this is a subject very dear to my heart.
And I'm Mina Hinch. I work at the Centre for Health Solutions, and I did the research on the report.
So the idea we had here was to take a closer look at the challenges that we are facing in Western Europe today, where we see that more than 50% of health outcomes are actually determined by other factors, so socioeconomic factors such as employment, education, income. This report is drawing from both academic and policy research on health inequalities and social determinants of health. The analysis we use here use a number of national and international data sets of health indicators. And what we provide here is evidence-based examples of good practice. In the report, we take a life cycle approach to vulnerable families, and we do that to illustrate how social determinants of health affect both maternity and infancy. It affects young children, it affects young people and people setting off in their working life, and it also affects elderly with increased frailty.
As you will see, health and social problems are worse in more unequal countries. So the greater the income inequality, the greater the inequalities as measured through the index of health and social problems. This includes physical health, mental health, drug abuse, educational outcomes, the chances of finding yourselves imprisoned, and also lifestyle factors such as obesity and social mobility. Community life, the risk of violence as children are growing up, and the extra increase in risk of teenage pregnancies, and just the general well-being of children are all impacted by the social determinants of health and income inequality. So, health outcomes are shaped by these social determinants of health that are beyond healthcare. A lot of attention is often focused on giving people access to healthcare to try and improve their health outcomes, and there is no doubt that that's important, and people who can access healthcare have got a better chance in life, but healthcare only determines a quarter of health outcomes. If you look at where the spending is, you will see that across these different activities, health, education, transport, all of which will impact the social ability for people to engage in their communities, the spending varies. You can see within these charts the variation in spending with the average, the dot on the graph, and these variations in spending also illustrate that majority of spending is still on healthcare, despite the fact that the social determinants account for about 50% of health inequalities. There is also a very complex relationship between healthcare spending and health outcomes. Health outcomes are often measured through life expectancy, but we've looked at both life expectancy and healthy life years. One of the factors that is in many of the academic publications is that life expectancy is improving to the extent that in most Western countries we're seeing very similar levels of life expectancy. But when you start looking at their healthy life years as measured at the age of 65, that people can be expecting to live, we see much more variation there, linked to an extent to healthcare spending, but it's not a straight line relationship at all. It's quite a complex relationship. Then the result of this is that we see within countries quite a wide variation. In fact, when we looked across Western European countries, we found more in-country variation in both healthy life years and life expectancy than we see between countries. If you look at a city like London or Glasgow or Paris, within those cities you see wide variation in health outcomes depending on where the people live in that city and the social inequality of the environment that they're living in. In the EU, as you see here, health inequality contributes to over 700,000 deaths a year, and there are 33 million cases of ill health influenced by inequality annually. Overall, health inequalities account for an estimated 20% of European healthcare costs, which is why by tackling these health inequalities we can both improve health outcomes but also spend the money that's invested in this area more wisely.
So why did we focus on vulnerable families in this report? This slide introduces you to what happens over the course of generations. Vulnerable children born into deprived families grow up to be adults that are highly susceptible for deprivation, poverty, and really bad health outcomes. And what we've also known from the work we do is that 10% of the most vulnerable account for 46% of social care spending. So we, in the next slides, will introduce you to some of the findings from the different lifespans. And as referenced earlier, we do that by introducing a set of family personas to bring the problem to life. We'll start off with maternity and infancy, run through sort of youth and adolescence, go through adult and working life, and end on the elderly, who are highly involved in the care for most parts of the family at times. So over the course of the last years, we've seen that maternity mortality has reduced quite significantly in the countries we look at, where sort of we started off from 35 deaths per 100,000 in 1990. We sort of reduced that by almost 50% in 2015. However, we know that mothers in deprived families, in vulnerable families, benefit much less from these improvements. And we know also that this impacts children born to these mothers for the rest of their lives. This is true both due to biological factors that result from cognitive stimulation. They are more prone to suffer from impairment of vision and hearing and have a harder start to develop good coping strategies for their emotional and mental well-being. And also, maternal behavioural factors influence other physical health aspects for children. For example, in the UK, we know that there's a 66.6-fold variation in admission to hospital for dental caries in children as young as a year old. And that is due most likely to a variation in utilisation of health behaviours that is correlated highly with areas of deprivation. So, if we look at the infants in these families, we know that one big factor can actually be changed to help them to develop better life changes, and that is maternal education. Every single year of maternal education leads to a 7.9 reduction in mortality among children under 5. And where you might say this is true very much comparing high-income to low-income countries, this is actually irrelevant of improving education from 11 to 12 or from 5 to 6 years. We know, again, that we have a long way to go and there is large in-country variation. For example, again, from the UK, infant mortality is more than twice as high in the lowest compared to the highest socioeconomic groups, probably based on educational factors, but also environmental and other issues that we touch on in the report. So these children, as I mentioned before, grow up to be vulnerable adults, and the patterns that this unfolds along is very much linked to education. We know that educational attainment is important for children due to two roots. One is that children with parents who have a high educational attainment are less likely to be materially deprived and, as you can see, then go on to actually develop better life changes and can expect to live 5.6 years longer than those in deprived families. We did actually look at it from a very interesting overview point of the Child Deprivation Index, which brings together an impressive amount of data. And what we did here is we ranked the countries we examine in the report along some of the factors that are related to deprivation. We looked at low birth weight, we looked at a vaccination rate, we looked at obesity in children, we looked at the level of exercise and smoking, we looked at educational deprivation as mentioned before, and we also looked at the chances to actually engage in employment, education and training. And as a sort of straightforward measure of deprivation, we looked at poverty rates. And what you can see is a very mixed pattern that is closely linked to other influence factors in the state, but we see that all countries still have some way to go. Coming back to the development along the lifespan, look at adults in the families. We know that, as mentioned by you, Meta, earlier, unemployment is a huge factor impacting whole families. And we know that looking at income and poverty risk, but we also know that unemployment rates increase the risk of mental health. This is due both to sort of the insecurity and uncertainty linked to unemployment, but it goes beyond that, and it also involves people suffering from low job security and uncertainty in their working conditions. What you see in this slide is that workers in low-paid jobs are more exposed to health risks across all the countries we look at. And we also know that with this inequality among sort of working and living conditions in adulthood, the risk behaviours around smoking, physical activity and criminal behaviour vary.
So that takes us to later life. We've called it elderhood, and the increasing frailty of this population, which often happens at a much earlier age in the people in lower socioeconomic groups. So older people in these lower socioeconomic groups are 30 to 65% more likely to face chronic disease, which in turn will lead to them being more vulnerable and being frailer and more dependent on support and the state in an area where they probably have less income to be able to provide that support. A lot of the vulnerable families rely on their older members of the family to help provide childcare and support, both material and physical support. So as these people age, that support also falls away, adding to this deprivation cycle. One of the areas we looked at was the access to good housing and the impact that housing deprivation can have on people's ability to remain healthy in old age. And there is a correlation between their access to such housing and their healthy life years. They increasingly need support with their activities of daily living, and again their homes are usually not suitable to provide that support readily. So largely we thought initially that we'd see that because we have so much about older age and frailty, that this group of people, the social deprivation index would not impact as much, but actually we found quite the reverse, and they are impacted just as much by the social determinants of health as any other groups. One of the aspects we considered, because this is what's helping a lot of people move socially and improve their ability to understand and self-care, is access to mobile health, to the internet, to computers, so that they can become more connected to their local communities. And again, we see here that internet use by age in the last 3 months of 16 to 24-year-olds versus 65 to 74-year-olds within these countries in the lower socioeconomic groups. So we're seeing improvements, but not the same as you will see in other parts of the population.
So what we've done there is looked at personas through the whole life cycle, and we can see that many, many different aspects of society contribute, and many, many organisations are involved in trying to solve these problems. The ultimate aim, of course, is to increase healthy life years and shift the spending. But to do that, we think we need to break down some of the barriers between different organisations and provide more integrated solutions that are designed specifically around individuals and their needs. But you know what? If integration was easy, it would have been done. And what we've found is that most Western European countries, in fact, most countries in the world, find it really difficult to really tackle the causes and impact of health inequalities. And part of that is because they find it very difficult to integrate across their systems and get organisations to work together. So we do often see people reacting to the problems that we've highlighted today, rather than going to the root causes and working out how to build from the bottom up integrated solutions to tackle them. So we think that partnerships and collaboration are absolutely imperative, and this is, you know, for all countries involved in this endeavour. Partnerships between academia, governments and the public. And I specifically think that engaging the public is incredibly important. And your last point there, Karen, about technology is absolutely critical, because if the public can be more engaged, feel more accountable, be better educated, be better connected, I think they may drive organisations to integrate as opposed to having to wait for them to do it for them. So that kind of brings us to more or less the close of our debate. But I think, Meta, it would be really great if you could just perhaps say a few words about what you think in terms of the key actions for stakeholders.
Definitely. So when we look at stakeholders here, there are plenty, as you say, both policymakers on a national and local level in government, who need to take a broader perspective on these issues, not focusing within the silos, but actually across. When it comes to both regulation, when it comes to structures, systems, so combine policies both across you could say, the phases of lifespan, but also across government agencies. Also consider new models of more integrated citizen-focused funding, could be impact bonds or impact investing. When it comes to public service providers, they need to ensure that instead of providing, which we see in many countries, vulnerable families with 6 or 7 case managers, 8 action plans, and 12 needs assessments, reduce that, have sort of a standardized assessment of social conditions, and ensure that we focus on their key issues and not just solving sort of, you could say, their side effects. Measure outcomes. We could not stress this enough. As it is right now, 10% of what we do in social services is actually evidence-based. Healthcare comes from a completely different outset, but focus on measuring outcomes in employment services, in social services in general, and stop programs if they're not working. So standardized assessment, measurement of outcomes, but also, you could say, cross-departmental cooperation around these families. We also think that a closer connection between academic and government agencies, NGOs and service providers would be a way to ensure that the very latest evidence-based knowledge will actually be of use in setting up programs and working to solve these social determinants of health, and use more analytical tools to both segmentize the population and use both predictive analytics and nudging tools to ensure that we're actually using the best programs available. Third sector, NGOs, private sector organizations, should be closer involved in this, both when you look at their own business, improving their safety and job security, but also partner up with public partnerships to ensure that their knowledge and their resources are actually put to use in this. And last but not least, engaging families. Ensure that families are actually brought along, use their motivation to change their situation. We see that oftentimes, because they have been involved or clients of the public sector, key clients of the public sector since they were infants, they are so used to being clients that just setting them, so you could say, free of government programs, it could be part of the solution. So engage them in co-design, co-delivery, and use their motivation. We see that it often brings along more effective and also inexpensive solutions.
All of this sounds quite challenging, and yes, what we've presented as largely the challenges that we see, but the report itself highlights a number of really important case examples where there is evidence base of interventions that work. Every single country that we looked at has got some good practice examples, and we've tried to pull out the best where there is clear evidence of impact and outcomes. And if these case examples could be scaled up and adopted more widely, we would start to see some real changes. We have case examples for each of the different life stages that we've talked about, but we also have a large number of case studies, case examples for how different countries are starting to integrate their services. So I would encourage everybody to have a look at those case examples.
Yes, and I'll just add to that and say, you know, one of the things that we're proud of at Deloitte is making an impact that matters. And I think this report is really fantastic in terms of the case examples that you've highlighted, because if we can take those cases to our clients, we can encourage the spread of best practice, lessons learned, and encourage people to adopt the good practice we see in the case studies in the report, maybe do some more scaling up. Maybe we could have a real impact that matters on some of these most vulnerable people in our society.
I agree totally. And one of the things that we perhaps should have said at the beginning is the reason we look through the lens of vulnerable families is because these are the most complex and most challenging groups of people. But our view is that if we can tackle it and improve outcomes for vulnerable families, then those same approaches, those same initiatives will work to address social inequalities much more widely. So yes, we're concerned with vulnerable families, but largely our focus is on improving health outcomes for the population as a whole.
Thank you very much for listening.